Welcome everybody. It is 9:30, so we are going to commence this morning's webinar. Thank you for joining us today. My name is Natalie Abraham. I'm the Managing Director of Sit for SECO, and myself and my colleague Neil Patel are going to be guiding us through the session this morning. Before I introduce our fabulous panel and give an overview of the 45 minutes ahead, I just need to cover off some housekeeping. We are recording our session today, and this is to allow us to share the content more widely following the completion of the session. I am going to ask all attendees to keep your cameras and your microphones off until the question and answer session at the end. In regard to the question and answer session, I encourage you all to use the chat function on Zoom throughout this. My colleague Neil will then pick the most hard questions at the end to put to our panelists on the call. And we commit to responding to all questions asked actually, and we'll come back to you via email following the session, and we'll also share the recording of the call with you. So I'm really delighted that I recognise so many of your names as friends of SECO, but for the benefit of those of you who are engaging with us for the first time this morning, I just wanted to set the picture. At SECO, we all spent our initial careers working in the public sector. I personally spent 12 years in local government and worked through austerity, reorganisation and all the associated cuts. And we as a collective, we encountered a lot of external support. And 7 years ago, we set up Sit for SECO to be different, to be better. And part of our commitment is not to be transactional. We build genuine, long-lasting partnerships with our clients, with the broader sector actually as a whole. And we want to share learning, showcase best practice, and through sessions such as this one this morning, commit to improving the sector and sharing with you all what we know. Today's session is all about reducing pressure on the health and care system. And I'm sure that every single one of us on this call would love to know the silver bullet answer that resolves national crises such as the cost of living crisis, the ongoing impact of Brexit, international crises such as the war in Ukraine, all of which do directly contribute to the workforce funding and provision pressures on our health and care sector. But we aren't magicians. But what we can do is ensure that locally we influence every factor that's operating in our local system to make sure that the services we do deliver are operating at top notch to serve our local residents. And that is what we're going to focus on today. Our panel of experts are each going to speak, and then at the end we will have time for question and answers. We have Professor Donna Hall, who will be speaking about the need for sustainable solutions. We have Joe Richardson from NHS England talking about the importance of getting it right in a home first context. And we also have our very own Sophie Coles, who will be talking about the need to assure ourselves that we are maximising our proportionate care. As well as asking questions via the chat during the call, we will also be live tweeting and posting on social media throughout. Our social media handles are shown on screen, and we will be using the hashtag #WhatMattersToYou, because as we all know, whatever we do, it has to be driven by the needs of our local residents. So please engage with us on social media, use the chat throughout the call, and let's keep this conversation going after the next 45 minutes. Now I'm delighted to introduce Professor Donna Hall, who's now going to speak to you. Donna is, we're very proud, a SECO non-executive director. She is also an ICS advisor to NHS England, chair of New Local, and the current chair of the Bolton's NHS Foundation Trust. So Donna, I'm now going to hand over to you. Thank you.
That's brilliant. Thanks very much, Nat. And hi, everyone. I'm not going to speak for a full 10 minutes because I think I was going to paint a picture of the state of social care in the sector, adult social care at the moment, but I think it's so well documented already. People know just how broken the social care system is for older people and for people of working age in the UK at the moment. And just going back in time, I want to spend more time, I'll give you more time to listen to some of the great potential solutions that we've got and listen to your questions and get some ideas from you about what we could be doing differently as a sector. But really, I just wanted to go back in time to the creation of the NHS and the creation of the welfare state back in the 1940s, and the Beveridge Report, which created the whole structure of the welfare state, acknowledged 5 years in that it missed one thing from the creation of the NHS and the creation of the welfare state, and it was care. And basically in those days, in the 1940s, care wasn't mentioned in the Beveridge report because care was something that women did for free within communities and within society. And then 5 years later on, he realised he should have included it because it's a really important element of a society that hadn't been referred to. And ever since then, I think social care has been the poor relation. You know, it's been hacked to death by different policy initiatives. Anything sustainable and long-term has been pushed into the long grass. So we're now hearing that the DILNOT recommendations won't even be looked at again until 2025. So, you know, we can't wait. We, people who are responsible for taking care and supporting people in our communities to live their best lives, can't wait till 2025. We have to come up with innovative, transformational solutions. And I'm really hoping that you like what we're going to talk about today. We've got some fabulous people on the call today, people who I know are actual really enmeshed in delivering some of this stuff. You know, I get fed up of seeing analysis around the ambulances queuing up outside A&E, including outside my own A&E in Bolton. And they seem to describe it as a hospital crisis issue, an NHS crisis issue, or an ambulance handover crisis issue. And it isn't. You know, they forget it's a social care issue. Again, as you will be, fed up with people being described as bed blockers, you know, that inhuman language that is used to describe the people that we care for and when we care for the most within our communities, describing them as vulnerable, not valuable. You know, during the COVID pandemic, they were passed out of hospital into care homes like a commodity. They were warehoused, you know, and that's some of the language that people use around people who draw on social care is outrageous. So I'm hoping today that you'll get some great ideas and things that you might be able to challenge us on at the end of this session. But really it is just a way of saying that there is hope. There are things we can do differently, even with the workforce crisis that we have, where we can't recruit people. I chair a brilliant learning disability social enterprise called Possibilities that covers the Northwest. And for the first time, we're struggling to get people to come and work at Possibilities. Great culture, great terms and conditions, but you know, the rates of pay are just not competitive enough. Local authorities have been cut systemically since 2011, and it's really difficult to get people to come and work in the sector, as well as the increase in demand. And you'll hear more about that in other people's slides. So that's it from me. I'm going to hand you back over to Nat now, and thank you for coming today.
Thank you, Donna. That's a brilliant introduction to our session. And just to remind everybody, whilst I have the opportunity to ask your questions during the chat, and we will come to as many as we possibly can at the end. And of course, the hashtags and social media handles are shown on screen. Now I have the pleasure to introduce Jo Richardson, who is the Therapies Improvement Manager for NHS England. And Jo is going to discuss proportionate care and effective discharge. Jo, welcome, and over to you.
You. I'm hoping that our tech will work. There we go. Hopefully you can all see that. So great to be here. It's a while since I've done a webinar, so be gentle with me, but hopefully you will enjoy what I have to say. So just for those of you who don't know me, here I am. I am an improvement manager. I'm an occupational therapist by profession. And I've been with the emergency care improvement support team for about 6.5 years. So working nationally across the country with systems, organisations, very much coming from an improvement perspective, not a performance perspective. As Natalie had said in her introduction, what I want to do is link the idea of proportionate care around the workforce challenges and fitting that in with home first discharge to assess as well. And you'll see that the principles are almost exactly the same. So I just wanted to set some context around why we are where we are. So most of you, certainly within the local government association, will know Newton Europe, the consultancy firm. So they obviously do a lot of work across a number of systems. And in 2019, they did some quite significant work. And these were their findings. You can see for yourself. I think the overarching theme that they found, and we still find that now, is the overprescription of care and support. So in 92% of the cases that they reviewed back in 2019, these people were being provided with a more intense level of care than they actually required. And we are still there today. And given the workforce challenges that we have to do things differently. We have to transform services, but we also have to move away from services, people fitting into services, and the services fitting into the people, and absolutely delivering what needs to be delivered for the local population. So some of the top 3 reasons: a perceived lack of capacity in the service, or a real lack of capacity. And I think it's fair to say it is there. In some cases it is perceived, but I've been to a number of systems where absolutely there is a big capacity gap in terms of the workforce required to deliver. And I'll show you a little bit of, and some of the other challenges that we're facing in the future. Risk averse decision making, so that goes back to wrapping lots of care, lots of support around people, putting them into another facility because people don't think that they're safe to go home. So we have to look at it from a positive risk-taking aspect and approach in the future. And very much, again, if we talk about what matters to the individual, they will tell you what they want and what they don't want. So actually, that any risk sits with them, not with the practitioner. And family disagreements. I'm working very closely with Salford Royal, and certainly conversations we have, there are a lot of situations that are dictated by the family in terms of what they think their relatives should have or shouldn't have. And they are difficult to deal with, but absolutely we must engage with them at a much earlier stage. So this is our issue going forward. So this is taken from the new recovery plan for urgent emergency care. So some of the things that we're dealing with now. So in the next 25 years, the older population will double. And the problem with that is that the workforce and the working age workforce to be able to deliver services for that older population isn't growing at the same rate. So there's a massive disparity in terms of the growth of the older population and the growth of those that need to look after them in later years. So as you can see, there is definitely going to be a high need for services. So again, that's why we need to think about transforming services and working very differently to how we used to work before. Again, some of the current pressures that we have around occupancy levels. So on average at 95%, what we would say is if an organisation, an acute trust, is running at about 90 to 92%, it will be able to manage its demand, and therefore you won't have the delays that we currently get across the system. And as Donna was saying, it's not just about the ambulances, actually it's across the system. So it's the risk in the community for people trying to get to hospital. When they do get to hospital, absolutely, it's that pressure in the emergency department, waiting in ambulances, waiting on corridors. And then once they get into the organisation, how they're managed, and then trying to get back out again. So it is a whole system issue which needs to come together to understand where the risks are, share the risk, but also work together to make it better. So you can see that the length of stay rose by 18%, meaning, quite a significant number of people staying longer than a week in hospital. And particularly for the over 85s, the longer they stay, the worse their outcomes are going to be. And certainly at the point at which they're ready to leave, they will be more dependent for a number of reasons. There have been up to 14,000 people, that's nationally, who don't need to be in an acute bed. So again, that number is rising, has certainly risen in the last year to 2 years. So again, we need to do something different. I think this is, the depravity. So yes, people who are in the worst deprived areas, they will use their emergency departments and their services far more than those who live in the less deprived areas. So again, needing to think about equality, health equalities, and how people access those services across the system. Just again, around length of stay. So you can see here that, again, it's the older population over 80s who have a longer length of stay and actually contribute to the higher percentage of people who are in hospital who don't need to be in hospital. So a high proportion, 60% of all the occupied beds are occupied by this set of individuals here. So again, we absolutely have to do something different in the future to avoid that. So looking around hospital discharge, what are the impacts in terms of health and well-being and outcomes for people? So I'm sure I'm not going to teach you to suck eggs here, but the biggest risk at the moment, and I don't know if any of you are involved in the Reconditioning the Nation campaign that's going on currently, that we have been supporting from an ESIS point of view, some great work going on across organisations and systems. But the issue around deconditioning, that happens very, very quickly. So the person can be deconditioning. The person who is waiting at home, who is unwell and is waiting for an ambulance, they will be deconditioning from that point, and that will continue all the way through their pathway in the ambulance, waiting in the emergency department, whether that's on a trolley in a corridor or in a cubicle, waiting to get to a bed, and then actually when they get into a bed. And I'll show you a slide of really what happens to people once they are on an acute ward, and in terms of how much exercise they get or don't get. So some real issues here. And obviously, if we can get things right, we won't have as many readmissions. We will have more people going out more independent, so therefore not a great strain on services to be able to support people once they are ready to go home. Obviously, we want more people to be going home and a very small number going into care homes, as you well know, and overall their health and well-being and their outcomes will be so much better. So this is what we talk about. Hospital-acquired harm or delay-related harm. So actually, when someone is in a hospital bed, the vast majority of that time is spent not actually active. So you can see here, standing or walking about an hour. So 23 out of 24 hours per day of a person being in a bed, they're really totally inactive. And as a result of that, as we've already talked about, or I've talked about, the outcomes then become far worse. And as you can see, those in the lower mobility category here, which will be the vast majority of older people, they are considerably disabled at the point at which they leave hospital again. So, and we know that if people are at home, they will naturally potter and be more active. So that's why it's really, really important that we only manage what we need to manage at an acute stage when we get people home and we get them confident back in their own environment and being able to get around again. So in terms of looking at proportionate care and making sure that we have the right support for the individual in terms of what they need and what they don't need, it's very much a person-centered approach. And this is where it maps to home first as well. So absolutely, if we get the care right, then all of these things help the individual themselves. So it is more enabling, it is more empowering. They actually have a better quality of life, so they can get out and do the things that they want to do, not restricted to, 4 calls a day, people coming in, 2 people coming in, talking over them, etc., etc. And really their quality of life is considerably reduced from that point of view. They are absolutely part of their care and they dictate what they want and how they want that delivered. That's no different to home first. Absolutely, better relationships with people, not having 10 million people coming into the home, but maybe 2 or 3 people coming in. So building a good relationship and feeling secure and supported in the way that they would like to be supported. As I said, far less invasive, so people can actually get out and about if they want to and engage in any social networks that they have as well. So that's why it's really, really important that we build everything around the person and what they want and empower them to tell us what they want. So when you look at the principles around home first, so this is taken from a document that my team within ESIS, so I'm part of the health and social care team, together with the LGA, ADAS, the Better Care Fund team, put together a practical guide, a how-to around home first, alongside the National Discharge Policy, which was mandated during COVID. So you can see some of the principles are very, very similar to making care proportionate. So absolutely maximising independence and not over over prescribing, but encouraging people to build on what they can already do. Absolutely, being at home is the best thing, and the majority of people, if you ask them where they want to be, they would prefer to be at home than anywhere else. It does rely on a positive collaborative system approach. So again, when you're looking at services and how you deliver those services and transforming them, it has to be across the system. The whole system needs to sign up to and commit to what they want to do differently. And if you don't have that, and you don't have that, the partners, system partners working together, then it will be really, really difficult to do any transformation in the future. I think the other thing is we talk about strength-based assessment, strength-based conversations, so certainly coming from a far more asset-based approach. So building on people's what they can do, but also talking to them about what they would like and what they wouldn't like. And again, it being very personalized to them. So you can see that there's a direct correlation between the two. It is about balancing risk. And as I said, it's about taking positive risk taking. I think when we had the policy, absolutely, that helps systems to be a bit more positive around their risk taking. Unfortunately, some of us have gone back to business as usual, but if you talk to the person and ask the person, that risk will sit with them. If they're fully informed of the decision they've made, it's not about the practitioner, and the practitioner shouldn't worry about the decision they've made. So just some research that was done in Scotland of around about 10,000 individuals that went through a hospital admission. And they found that 46% of people over the age of 85 would die within the first year of a hospital admission. So a very high proportion. And that's linked to everything that I've said before, the delay in the community, the delay in the emergency department and waiting a long time, trying to get to a bed, and then probably being overmanaged and having a longer length of stay overall increases the mortality rate. And if any of you are on Twitter, if you hashtag last 1,000 days, you'll find lots of information around that. And the average person over the age of 80 has about 1,000 days left to live. So it is about where would they like to use those days, and they would certainly want to be at home. This was just a quote that I thought was, I always like to sometimes finish on a quote. So it is about not being the strongest of the species that survives. It is about being the most adaptive to change, and we all have to adapt to change. We have to do things differently. Thank you very much.
Thank you so much, Jo. Some really interesting research, facts and figures there, and also a clear imperative that integration of services is really the key enabler for improvement in this context. So thank you very much, Jo. Just another reminder from me to continue to use the chat function. I can see many of you are, and to engage with us on social media. Now, last but not least, I'm very pleased to introduce Sophie Coles. She is SECO's Health and Care Lead. Sophie is a registered OT and has spent the last 15 years working across NHS and social care in both England and Scotland. And Sophie is going to talk about maximising proportionate care in the context of the social care crisis. So, Soph, over to you.
Thanks so much, Natalie. That's great. Hello, everyone. Lovely to be here and see you all. Lots of familiar names, which is lovely in terms of those of you that could attend today. I'd like to start by setting the scene for you, and would like to take you to a few articles. When you receive the presentation, you'll be able to dive into these, but I'd like to talk to you a little about some of the challenges that are really facing us around the importance of proportionate care. So we know some of these have been touched on already. In April last year, 40,000 people were put at risk while waiting on an ambulance. And I think the ambulance delays are a significant challenge for us, and particularly for acute staff, because the level of people requiring, admission to hospital, particularly to A&E departments. My uncle's a paramedic and says to me on a weekly basis, we've got 13, 14, 15 ambulances queued up outside hospital with critical needs, and we cannot get them in because they can't support people to get home with a community care package. So we have to get this right. The statistics are shocking on the number of people who are awaiting community care apportionment. In Scotland, 70% in December of delayed discharges were due to not being able to receive a package of care. So significant challenges. We also know that the underfunded nature of social care is having a significant challenge. The Local Government Association published an article a couple of weeks ago that said it's actually not £2.1 billion that is required, it's £13.1 billion just to enable local authorities to meet their statutory obligations. So significant underfunding. And we know that, you know, the underfunding within social care, and you know, it doesn't enable, we can't have a sustainable NHS where social care isn't financially sustainable. And then the last statistic is absolutely heartbreaking, that nearly 30,000 older people died last year due to delays in receiving social care. I'm going to take you to the next slide now. Okay, so let's have a look at delayed discharges for a while. Delayed discharges in terms of, let's look at it in terms of costs first, and then we're going to look at it in terms of some of what Joe touched on in terms of impact to people and families. So within England, we know that the average cost is £257 a day for somebody to be in hospital. And last year, £1.2 billion was the total cost to NHS England, £3.3 million of taxpayers' money per day in people remaining in hospital who do not have a medical need to be there. In Scotland, over the last 10 years, you can see the figures, £1.26 billion was lost of public money because people were not able to be transitioned to appropriate placements. And then from April to October last year, just £111 million alone within those few months of delayed discharges. And then data for England from December last year shows on average nearly 14,000 people per day remained in hospital despite being ready to leave, which was a 30% increase from this time last year. These are people, these are mums and dads, these are spouses, these are people who want to be at home, but who have to remain in a setting. And as Joe said, the deconditioning that happens to people when they're in hospital without a medical need is significant. So we know that there's poorer outcomes for people, and that loss of independence, obviously an occupational therapist, that's what matters most to me, that people are maximising their independence, but that doesn't happen when people become delayed discharges. So 61% of older people who are hospitalised decondition in hospital. And then the readmission rates are tripled for those individuals within a 30-day period. And 1.5 million care hours could not be provided by local authorities last year, which increases the likelihood of preventable admissions, again, deconditioning, and further delayed discharges and inappropriate discharges, where people are moved to what may be viewed as an intermediate care placement, but isn't intermediate, becomes a much more long stay placement for them, where again, they decondition often. Okay, I want to have a look at the infographic on the right-hand side. This is something that we put together following the ADAS publication in August last year. And we put this together because the statistics horrified me. So November 2021, there were 200,000 people in England waiting to be assessed for care and support. These are people who have, let's say, potentially a moderate or critical need for assessment. So 200,000 people last in 2021. Look to last November, that number had doubled to 400,000 people waiting to be assessed. These are people with often critical needs who often become preventable admissions, where if that community care support had been in place, that reablement had been in place, that care and support in terms of specialist equipment had been in place, we could have avoided somebody becoming an acute admission who then becomes often a delayed discharge. So social care, we know, is in crisis. People over the age of 85 are the fastest growing demographic in the UK. And the ONS are saying by 2050, the number will have grown from 1.5 million to 5 million people. So at SECO, we really, really understand the importance for integrated care systems, for health and social care partnerships, for local authorities to maximise proportionate care. And what that approach does is it really helps us to, look at reducing the preventable admissions, look at the delayed discharge figures and how we can streamline and support discharge to happen more fluidly, support with the recognition of the challenge that the ICSs and HSCPs have and providers have in terms of staffing. Both Donna and Jo touched on that. So the chronic shortage of carers is significant, and then the monumental pressure that's on the NHS and local government financially. So what our approach does is it looks to maximise that capacity in the community where there are significant delays in deploying new packages of care. We touched on some of those statistics in the last slide. Proportionate assessment skills are improved and integrated into the workforce through dynamic moving and handling training, and we're going to come on to talk about that a little bit more. So the key challenges for ICSs and HSCPs, in my opinion, and from my experience, are often, when we're talking significantly here about single-handed care. So often what happens is specific teams or services are trained, but it's not viewed as a whole systems approach. So it might be that the social work, the community OTs or the intermediate care OTs are trained in how to conduct proportionate assessments. But what happens is, if acute continue, as an example, if acute continue to have feel that risk aversion and they conduct those assessments and overprescribe care potentially, we're not looking at this from a whole systems approach. So my real recommendation for anybody that's undertaking this particular type of project needs to look at the impact of this, but also the provider perspective. So when it's a whole system, we're talking about community, acute, social work, NHS, and then our provider colleagues. Percentage of outstanding reviews. Everywhere that I've worked in the country, everywhere has had significant challenges around outstanding reviews. We've got challenges around pathways across services. We've got challenges with the consistency of moving and handling training and how often that's happening and what level and depth that goes into. We've got challenges of overprescription of care. I've seen this myself, particularly in certain areas and certain fields where the risks are viewed to be so high and perhaps clinicians don't feel safe around the risk assessments they're conducting. So the care can be overprescribed. And then obviously financial sustainability. In terms of co-production, like I touched on, so ICS, HSCP and local authority operational teams, we have to co-produce this when we're creating these type of models and programs. We cannot do this in isolation. We have to recognise the value of providers, and providers are the ones who are conducting moving and handling day in, day out. They need to be on board from the very beginning of creation of this type of project. Our equipment stores, which are so often left to the last minute when single-handed care programs are brought in, what kind of equipment do we need? Are we using equipment that's fit for purpose, or is it antiquated and not sufficient anymore? And then our commissioners, we need to support our commissioners to understand the benefits of this type of approach and to work co-productively with providers in terms of contract management. Okay, so let's look at assurance. Assurance, as we know, lies at the heart of the work of health and social care leaders. The provision of all health and social care involves risk, but being assured is foundational to the successful identification and management of risks. So our approach supports the ability of system leaders to agree and share the possible risks, and then the definitive successes of embedding a proportionate approach to care delivery. And we are experts in maximising proportionate care. So our programme of activity maximises organisations' community care capacity and supports challenges around timeliness of hospital discharges. So our A&E product, which stands for Assurance and Evaluation, provides that assurance and evaluation assessment of the current status of single-handed care approaches within your organisation. Lots of people are already undertaking, single-handed care approaches, but what we come in and do is look at how from an assurance perspective, how successful are they and where are the gaps? The output of the product increases organisational confidence that community care resources are being deployed at their optimal efficiency, and assesses the fluidity of internal processes. So where things are getting stuck, where the pathways, particularly when it's transferred between teams, where that person is becoming stuck in the system, we support with looking at the fluidity of the processes. And then the output will provide recommendations and next steps on how to maximise community care resources from that single-handed care perspective. So we conduct our A&E assessment in organisations within 25 days. So it's a short, sharp piece of work. And we provide clear recommendations on where improvements can be made to optimise outcomes and maximise proportionate care delivery. We want people who need to journey through a system to do so in the smoothest way so they can get back home and not be stuck because of system failings. So yeah, we'd love you to get in touch with us. We have our website, we have our specific MPC, so maximising proportionate care email, and then you've got my direct contact there, and you're very welcome to use any of those routes to get in touch with us. We would love to help you. We know that we can do things, systems can do things better, and we'd love to be able to support with that. So now it's time to move on to questions.
Thank you, Sophie. That's fabulous. And you're right, we now have exactly 10 minutes to take questions that have been asked during the chat. And just to kick us off with that, I'm really interested in exploring kind of the whole systems approach a little bit more in our discussion, and kind of the theme that obviously the solutions to this huge challenge are around us working better together. But Karen McNeil on the chat has referenced the third sector, and I'm really interested in understanding what the panelists' perspective is on further third sector involvement in tackling the crisis. So Donna, I'm going to start with you, if I may, and then I'm going to bring in the other panelists to take your thoughts.
Yeah, I think it's so essential that we work with the third sector, the community and voluntary sector. One of the things we did in Wigan was we put 13 million into something called the Community Investment Fund, so we didn't commission it in a darkened room, imagining what people wanted and how people wanted to spend their days. We asked people, and we commissioned bottom up based on what local communities said was missing in their local neighbourhood. And we funded all sorts of things like dementia support project, not called a dementia support project, but a rugby memories group. So Wigan's a big rugby place. And we focused it on an asset-based approach, strength-based approach. We thought about assets in the local community and transferring them to community organisations, so swimming pools to a swimming club, libraries to groups who could manage them better than we could, and really try to think of the community organisations as assets in the local area and partners in the transformation of social care. We managed to add an additional 7 years of healthy life expectancy in the most deprived wards by working differently with the sector.
Well, thanks, Donna. Yes, great. Jo, what are your reflections?
Yeah, no, I mean, great to hear what Donna has done in Wigan. I would say I don't think we've tapped into voluntary sector and third sector social enterprise organisations as much as we could have done around this agenda. We know that quite a number of elderly people, they lose their partners. They've had their partners for 60 years. Some of them, they become extremely isolated. They're bereaved. And what will they do? They will go to their emergency department, get themselves into hospital because it's warm, it's comfortable. They get 3 meals a day and they get some social interaction. So they're terribly socially isolated. And we know that people who are bereaved within the first 6 months, they will reattend. So there's lots out there, and the voluntary sector are always wanting to support people getting home. So we really absolutely have to use them more. And I think when we talk about bringing the system together to deliver what needs to be delivered, when I talk about the workforce, it's not just about AHPs, it's not just about social workers, it's not just about care workers, it's the totality of the workforce. So that is your voluntary sector, your third sector, social enterprise, the local hairdresser, the church, the gym. All of those things are the totality of the workforce that we need to tap into to support people in the future. So I think there's more that we can do in that space. Definitely.
Absolutely, Jo. And so beyond the third sector, there's obviously the provider market too, who clearly need to be fully engaged in this. What are your thoughts on that? Picking up one of the...
Absolutely. I think my experience would say that the third sector interface in Scotland is a lot stronger than it is in England, from my personal experience of working within health and social care partnerships. Scottish Government have invested significantly in the third sector, and we've seen some great pieces of work undertaken in Forth Valley, for example, where they have a TSI who, should be showcased, in my opinion. They offer, one-stop shops. So people have opportunities to avoid, like you say, Jo, that A&E contact, which happens so often, or that GP contact, which we hear a lot from GPs, that there's a huge issue around loneliness, isolation, like you said. In terms of the provider, provider market, there's some fantastic support networks for providers in terms of some of the groupings that happen down in England, and I think there's a huge opportunity for us to enable the voice of the providers to be heard much more with much more strength than currently is. So there's a huge amount of work to be done. I would say particularly down south with the third sector than we have over the border.
Nat, if it's okay, I'm just wondering, we talked quite a bit about providers, but I wondered if it's okay to ask a provider what they think about what they've just heard, if that's all right. And I know we've got Rachel Law, who's a fantastic chief exec at Possibilities. Just wondered if, with a real asset-based approach and a happiness manifesto for staff and people who draw on our services. I don't know what you think, Rachel.
Sorry, can you hear me? I couldn't unmute myself then.
Yeah.
I think the statistics are really, really scary. I was just sat listening in horror about some of the, statistics around unmet care needs and around, people struggling to be discharged from hospital. And I think, real partnership working needs to come into play. And I think that there's not a great partnership working between sort of the ICBs, social care. That might change in the future, but there's still people working in silos, providers as well. I'm constantly saying to commissioners, let me work in partnership with you. Let me tell you about some of the ideas that I've got to try and support the fact that I know you've got to be as efficient as you possibly can. It's public money, but again, that is falls on deaf ears. We did put a paper out there, 10 ways to support local authorities to make efficiencies, and we kind of circulated that far and wide, and we had nobody contacting us about taking up some of our initiatives. So I think we've got to really look at partnership working if we're going to get some of those figures down. Very scary, very interesting. Thank you.
Thank you, Rachel. That's great to have your insight too. And I think that the challenge is that partnership working is difficult, and it involves people to really take, there's a theme of risk in the chat, but actually doing partnership working well means taking a risk, because it means putting something that you value, dear, out there and trusting other partners to deliver that well. And that trust aspect between partners takes time to develop. But the good thing is there's common purpose across all the partners working in this space. We're all in this to do a good job, to improve outcomes. So that common purpose should be the catalyst for us working through the connections, building that trust, and ultimately us taking those risks to work in a more integrated way. And just conscious, we've got 3 minutes left, but with risk as a bit of a theme, certainly in my mind, in both a positive way and as a restricted barrier, maybe in terms of current ways of working, I'm really interested, just as a final question, to pick up risk in the context, Joe, that you were talking about it, in actually how we take risks in a more positive way and how we allow people to make judgments themselves for personal risk they want to take on, that will hopefully encourage more independence and improved outcomes. It was a question in the chat, Joe, and I'm keen to know your thoughts.
Yeah, so pre-COVID, I did a lot of workshops with multidisciplinary teams around embracing risk. So as an occupational therapist, we have an Embracing Risk Enabling Choice document that was published back in 2017, I think, through the Royal College of Occupational Therapy, and myself and my line manager at the time were asked to review that document. There wasn't very much that we felt was missing from that. And what I have said is those people that have access to that document, they should share it with everybody, because actually risk is everyone's business. It's not just therapist business. I think we're worried, certainly the work I'm doing with Salford Royal, there's certainly worries around complaints. And so I think that interferes with some of the decision making. I think you're absolutely right. When I talk to therapists, I think a lot of it is around the responsiveness of the services for the people when people go out and how quickly they get picked up. So if they don't think that service is going to be responsive, then they will hold on to that individual for longer. They will put more support around them because they don't trust that the service will pick them up in the way that they should. And you're right, that happens over a longer period of time, but you've got to start somewhere. As I said in my workshops, none of us make a decision where there is 0% risk, and 100% safety. We will all make decisions every single day that will have a level of risk and safety across a spectrum. But for some reason, we take a different approach to that when we're looking after people, and all of a sudden, well, it's too risky and it's too unsafe and we can't possibly do it. Actually, we need to just inwardly think about how we make decisions ourselves. And it is absolutely around, just ask the person or ask their relative. They will tell you, and they will tell you what they will want to sacrifice and what they don't want to sacrifice. They will make unwise decisions, but then it's very important within an organization, but across a system, to support one another when things go wrong. And what we always have said with ESIS, whenever you're starting something new, things will go wrong, but that's not the opportunity to point fingers and to blame. It is to learn together. So it's making sure that you have an operational forum when you're starting things, new initiatives, and starting to work together and transform your services, that you have an opportunity to come back together, to look at what's happened, celebrate your successes, acknowledge what's gone wrong, and then say, okay, so how can we learn together to make this better the next time and mitigate that problem? That's, you know, and it's easy to say. I know it's more difficult to put into practice, but we have to open ourselves up a little bit more around risk and give it back to the individual at every opportunity that we can.
Absolutely. Need to be brave. Doing things differently means taking brave choices and making bold steps. But as Donna said in the chat, the biggest risk really is remaining the same and doing nothing. We have to try things differently. Absolutely. And on that note, I would like to thank our panelists for the discussion that we've had this morning. I would be really keen to keep the discussion going around the solutions, around how we can do things differently, around how we can build really conducive, high-performing partnerships locally that really improve our health and care systems and the integration that operates across them. So thank you ever so much for joining us this morning. Keep engaging with us on social media, and we will come back on all the other questions asked in the chat and share the recording in due course. Thank you, everybody. Have a good day.
Thank you.
Thank you.
Take care.